Right on.
All right, welcome everyone to another install of CV Weekly Rounds at the Heart Center. This week I've invited two great colleagues and friends, Sue Morris and Dr. Andrew Clark. And Sue's presented us before. She is a clinical nurse educator and specialist here at the Heart Center and has worked with us for years and years and years, is really responsible for a lot of the great training that occurs with our nurses, both senior and junior alike, and has been an integral member of the Heart Center for many years. So we're excited to obviously have her as a part of the Heart Center and for her to present on this particular subject in conjunction with Dr. Andrew Clark. And Dr. Andrew Clark has really been here since the get-go. He is one of the originals at the Heart Center, has been an anesthetist for many years, has been a cardiac anesthetist now predominantly for the past few years, was an intensivist along the way, has a great interest in code blues, not because he causes them, but because he is part of the teams that runs them and is in charge of that. And then last but not least, he's an avid musician and just a fantastic person all around. So very excited to have these two talk to us about code status and code blue, a tale of two codes.
Thank you for that lovely introduction. I'm hanging out with my co-chair. We work well together, and so we're going to do a quick presentation here for you and have some discussion. So we're going to look at the DNR levels in Horizon, talk a bit about the pros and cons of designating code blue status. We're going to look at the jargon around our discussion with patients. Then we're going to take on a little bit of a different journey and talk about resuscitation, our dream team. We're going to talk a bit about measuring performance and doing group simulations, and then talk a bit about debriefing. So a historical perspective. So Andrew was probably a very young practicing dude in the 1960s when CPR first came along, was introduced by 3 American scientists. And so it became a routine procedure. And then by the 1970s, we realized maybe we shouldn't be doing this for every patient. And that's when discussions about do not resuscitate. So DNR and DNAR, do not attempt resuscitation, mean the same thing. So we started to have some conversation about maybe we're doing some harm. And so when we talk about how do we achieve a code blue status, we should be taking into consideration 3 different things. First, allowing the patient the self-determination of determining what is best for him or her. Well-being, and Andrew and I have had the discussion about well-being is the patient's view of quality of life, not the healthcare provider's view. And then it needs to be fair and equitable without cost implications discussed. And Andrew, you talked about autonomy yesterday.
Yeah, there are 4 pillars of autonomy in determining what a patient really wants. The first pillar is the adequacy of information that they have. The second pillar is that they have enough time to digest that information and ask questions as necessary. The third pillar is the absence of coercion, and coercion can be either external. For example, if I were to say to a patient, we can resuscitate you, but you'd probably be a vegetable, so what do you want us to do? That's coercing a patient to what I want them to do. And then there's internal coercion, which is perhaps the fear a patient might have of asking questions or of wanting to know what's going on when they don't. And that's internal coercion. And that happens particularly in hospital where patients don't feel as if they're really in control of either their disease or their treatment. And then the fourth pillar is the patient's worldview. If they're making a decision that the family tells you, wait a second, that's nothing to do with what my mother or father really wants, that has to be brought into consideration too. Back to you, Sue.
Thank you. So when we look at Horizon Health, we have different levels of do not resuscitate. So we have the full code where full meal deal, everything is provided. Then we have a level A, B, and a C. So level A would be the patient who can continue to go to intensive care. They may receive BiPAP or non-invasive ventilation, but we do everything up to excluding intubation, defibrillation, and CPR. That's a level A. Level B, the patient can still continue to be treated for whatever illness they have, but they do not want any heroics. And then there is some question about whether we go to ICU or not. And so it says no ICU or CCU care, and that becomes a blurred line periodically. The level C patient is the easiest. He wants to be managed. He wants his comfort maintained. He wants no heroics. We do this really well in a palliative care unit. We don't do it so well outside of the palliative care walls. And I think we need to get better at consulting our colleagues in palliative care, because palliative care does not have to occur within the walls of anywhere. It can be provided quite easily anywhere in the building. In 2020, we made a change, and I think it was a change for the better. So we had two levels of DNAR level A. We had with defibrillation and without defibrillation. And as Andrew and I talked about, we had patients in nursing homes who had no AED, but they were a DNAR level A with defib, which meant you did not do CPR until a defibrillator came along, which really just made no sense. So that has been eliminated from our options. I'm going to speak about this.
We're trying very hard to make sure that the identification of a patient's level of care is easy for the care team. What we're trying to do is either have something on their armband that identifies what their level of care would be, or maybe to have something as a sticker that can be put on the patient. We're trying to avoid people going to a code and then having to look in the chart to see what the patient's code status would be. This is something which is ongoing. We think it's extremely important, and we'd appreciate any input from any of you guys in terms of how easy it would be to do this. We've thought about things like maybe we'll just put a red heart on the armband if they're a full code, and then different colors of heart for different levels of DNAR. But we'd appreciate your input on that.
Thank you. So there's pros and cons to having a predetermined code status. So the biggest pro is when a patient is off unit, say they're having a CT scan, everybody knows the patient's wishes. Informed consent, and if it's done well, is really a true reflection of what the patient and the family would want. Then the cons are oftentimes it's not communicated to family members, and then the patient is incapacitated and nobody knows what is happening. Oftentimes it doesn't get revisited when the patient gets a new diagnosis or a new admission. Sometimes there is the mindset that DNR translates into do not treat, and that's a big fear. And then there is also the complexities of a chemical code only, a slow code. No, slow code's awful. A do not shock. It just becomes very confusing. So those are some of the pros and cons. The jargon around discussion. Burden to my family. The word vegetable often comes up. Do you want us to bother resuscitating? Do you want us to break your ribs and bring you back to life? So be really mindful. And Andrew, have you got comments regarding that?
I think this is a discussion which ideally would be taking place within a family environment where people aren't afraid of talking to each other. If the first time this is presented to you is when you come into the hospital, or even worse, when you're 5 minutes away from an operation, then it's going to be very difficult to get anything meaningful from that. And the patient just says, just get on with it. Just do whatever you think. A lot of people in their cultures are uncomfortable talking about end of life or cancer or anything like that. And so this kind of thing really should be started off very, very early. And hopefully, by the time a patient comes into the hospital, they know what they want and they've told their family. Back to you.
Thank you. So when we talk about DNR orders, they came about because of poor resuscitation outcomes. And so when we look at our DNR process, maybe we should be taking a little more upstream approach and looking at how do we improve resuscitation so that the discussion around do not resuscitate is a little bit more clear. So survival with good neurological outcome in my career has improved by 50%. Still doesn't make it really great. It's still only 10 to 20%. But when I first started nursing, it was 5%. So we have gotten better. When we look at in-house cardiac arrest, there is some robust data that talks about rapid response teams and how they can improve outcome up to close to 65% compared to facilities without a team. Moncton has a team, Fredericton has a team. We do not have a team at the St. John Regional Hospital, and that has been a bit of a bone of contention for our Code Blue committee, but that's a discussion for another day. So significant data exists we do a fairly good job of resuscitation. Where we are lagging behind is the post-resuscitation care. Are we using targeted temperature management? Are we hemodynamically optimizing all of our post-code patients? Are we offering early revascularization for ACS patients? And so there are some things that we can work on to improve. And I think we need to spend some time on those. So maybe that will give us a little bit of a less negative perspective on resuscitation. So Andrew thinks this is our dream team, and so do I. 6 people, everybody else would be outside of the room. You have Andrew standing here with his hair in a ponytail. You have the compressor opposite the defibrillator. You have an airway manager. You have a medication RN, and you have somebody who is recording. The recorder's job is not just to record. The recorder has taken on a few new roles. The biggest one is to count and give an auditory cue for how long we are off the chest. So let's say we decide to do a point of care ultrasound, which is very much brought forward in the 2020 guidelines. Time recorder should be saying 10 seconds off the chest, 20 seconds off the chest. So everybody has an auditory cue. So we think this is the dream team. In Horizon, Andrew will tell you a little bit about our simulation initiative that we have put forward.
One of the things that's come out in the last few months since COVID is that we had a request from somebody in a peripheral hospital, should we call all Code Blue resuscitations what we call protected Code Blue, where you have to put on protective PPE to ensure that you don't get COVID. What we found when we performed the simulation was that unless a patient's in an intensive care unit being looked after by people who are already wearing full PPE, there is at least a 3 and maybe as much as a 4-minute delay before any resuscitation measures can even be attempted in those patients. So when we were asked, should we make all code blues protected code blues? The answer is definitely not. You only do a protected code blue in somebody who you either know has COVID or you're very, very suspicious that they do. And that's an important thing because a delay of 3 minutes basically is a death sentence for people who don't have COVID and are arrested for some other reason. That's an extremely important point. Simulation then becomes something that we can study how well we do things and come up with protocols to improve it, like a flight simulator for an aircraft. Pilots have to do this at least every 6 months, and there's no reason why we can't apply that to hospital staff, and particularly residents in training who are coming to us from other areas. Back to you, Sue.
So stay tuned. We do have an initiative coming on board that the St. John Regional Hospital Foundation is going to support. So we may have some good news with regard to a resuscitation program. Debriefing. Debriefing has now been a responsibility pushed on to the code team leader. And I think it's tough that we say, okay, code team leader, there you go, start debriefing. If you have no education or training on it, it's very difficult. And so there's 3 types of debriefing, and I'll go through these very quickly. A hot debrief occurs immediately after the code. This usually only happens when the patient has expired, because the code team leader is often busy in the ICU immediately after. But you need to look at, let's celebrate what we did well. Let's look at opportunities to improve. When we do a warm debriefing, it's a few hours after the event, and sometimes people can be more emotionally ready to have a discussion. Some of that maybe emotion has been diffused a bit. And then there is the cold debrief, which happens days to weeks after, and this really looks at process. And so I am educated as a formal debriefer. I would love to have a conversation with people about how to debrief, so don't be shy to contact me with regard to that. So in summary, we just want to say code status conversations should include all of the healthcare team. We need to ensure that it is done with a well-competent patient and family, not at the time of crisis. Beware of our jargon and statements that lead or coerce the patient. Quality of life is identified by the patient only, not the healthcare provider. Improving resuscitation outcomes can potentially lead to a more positive discussion about code status. Do not offer a new medical diagnosis and a code status discussion at the same time. And debriefing can potentially lead to improved discussions about code status. And that's the end of our conversation. Family physicians and nurse practitioners are really in a pivotal role to have the code blue discussion in a well patient and family. And thank you for your attention.
That was outstanding. Thanks, both of you. That was really well done. When I'm just going to stop sharing your screen for a second. Sure. When I initiated this topic, honestly, I had an idea of what it would look like, and I tried to relay that over to you too. And I think you both nailed it in less than 20 minutes, which I'm super impressed by. Okay, lots of chat on the Dr. Novikova, I believe, if that's Olia, raised her hand. Feel free to unmute yourself and ask your question.
Hi, good morning.
Hi, Olia.
I think you might be muted.
Oh, sounding a little chopped up there. Well, yeah, not sure what that's all about.
Maybe you can type your question, Olivia, because we
Yeah.
can't really hear it.
Okay, so while you're typing your question, I'll just get question from Dr. Lugo. How often does debriefing occur amongst physicians in your experience?
Andrew?
Not often enough would be the overarching statement, and not often as we would like. I think we basically do cold debriefings when we do mortality rounds, and all of the departments do that. We know that some do it in more detail than others. And from my own experience, I can say that the ICU mortality rounds that we had were done on selected patients, everybody who died in the ICU, and they were pre-reviewed by the person doing it for quite a long time before it was brought to the group. So time is important, and I think if we're able to provide time to prepare properly, then these things will be done better and they'll be more meaningful. I hope that answers the question.
Yeah, I think that's a great point, and I think it's all about in the prep, and the same goes with M&M rounds. So I mean, JF had the question about how can you provide some advice on late debrief, I guess the cold debrief, and how best to conduct that, structure, etc. So maybe just expand on that a little bit there, Andrew and Sue.
I'm going to give Sue that one.
Yeah, so cold debriefing really is the probably the least effective for the healthcare team, but most effective with changes to process. So an immediate hot debrief or even a warm debrief allows people to, so as a physician, starting out with what we did well. Let's celebrate what we did well, and let's look at an opportunity to improve. And so it has been my experience in both in the literature that says the co-team leader should not identify the opportunities for improvement immediately. He or she should allow the team to look in at their own personal response. And if they are not bringing forward, so for example, let's say a registered nurse did poor quality CPR. I would expect that the registered nurse should have some insight into that and be able to bring that forward and say, my CPR quality was inadequate. And so if you can bring forward your own inadequacies, it is much easier to palate than when somebody else brings them forward.
So true.
But if that's not brought forward, you can give leading phrases like, what do we think the quality of the CPR was like during the process? And then that could lead into conversation.
You know, I mean, oftentimes I feel like we rely so much on the oral debrief that we don't give enough chance for people to, do a written debrief, like even just like a quick, tick box, were you happy with how that was run? Could things have been done better? What could that have been? Just very quickly, and then jot those notes down immediately, and then just say, here you go, and put it in like in an anonymous type style box. And at least that's there, right? Because if, like a 360 review, if you don't get the written feedback, then you're never really gonna, the oral is always a little bit watered down depending on the individuals involved. A question that I have, and then I'll go to Chris's question. You brought up a really interesting point about, code status and that discussion. And one of the big issues that I have with code status discussions is that I feel that it always happens for me because I'm kind of at the end of the spectrum of care. It happens kind of at the wrong time. It's not really the right time to suddenly start, if I'm offering heart surgery, to start talking about the pros and the cons of resuscitating them when we're doing basically a 4-hour resus, in a manner of speaking, in the OR. But having said that, is there an option? I think you touched on this, which is great, having the family doctors and or nurse practitioners kind of initiate that discussion, and maybe having an organ donor card style, sign on or sign off early on, so that, the discussion has at least been initiated prior to entry into an acute setting.
Yeah, ideally, the dream team starts off weeks, months, or even years before the patient has a problem. And the first member of that dream team is the patient's family, who realize that there's only one thing you can say about everybody on the planet, and that's we're all going to die one day. And if you're not prepared for what to do about that, then most likely people are just simply not well enough informed. And I think this is something where we need to go outside the hospital to public media and try and spread information about what the quality of life is like after a resuscitation, why CPR is so important, because it's really the only thing that makes a difference in long-term survival, is provision of adequate, good quality CPR and or AEDs when you most need it, which is when it happens.
Yeah.
So if we could do that and get media involved, maybe even television and radio involved in saying, listen, this is something that everybody needs to have a conversation about, I think people would be less frightened then, because there's always the white coat syndrome. You come into hospital and the first thing a doctor asks you is, do you want us to resuscitate you? That presents us as being an extraordinarily paternalistic and scary institution, which we
Absolutely.
don't want to be.
Well, you know what? The lack of good quality info, the lack of time results in coercion. And
Yeah.
before you know it, all of your four basic, principles, with the exception maybe a worldview, are all squashed, right?
Exactly.
I mean,
Yeah.
So last but not least, Chris had a question about simulation. I think simulation, for running a code is critical. And I love the dream team concept, because oftentimes there's just too many people in that room, and many of whom are not doing anything. You would never have that many unnecessary people in the OR unless it was a tabby when we first started, but that was the exception. But having said that, his question is around CALs, and I think it's more specific to cardiac surgery, obviously, and whether or not is there something in the works to maybe kind of get that simulated, for cardiac surgery patients in the ICU. And I kind of have a half answer to that too. Go ahead, Sue.
So we put forth a proposal to senior executive with regard to a simulation program for Zone 2. Included in this was COVID. So COVID was the impetus for this and kind of how we thought we would push it forward. But ECMO, we need to do lots of sim for ECMO, and it would be a nice controlled environment to have whoever you need to do that. ACLS, BLS, different types of resuscitation. And so our hope is that there is one sim manager who is educated as a sim provider, who is also either a nurse or an RT. And so you would go to him or her and say, hey, I would like you to offer a sim with regard to this. I'm a cardiac surgeon. I can offer you the expertise with regard to this. Can you put it together and make it happen? And that's what we're hoping in the next 6 months occurs.
That's great. Well, perfect. I really love that initiative. And I know that the nurse educators in the ICU have also looked at CALs as well, Chris, and Jillian had a great interest in that, but we need to push the agenda forward. Both of you, thank you so much for your time and for your effort this morning. It was fantastic. Great discussion. Thank you everyone for joining. Next week, infective endocarditis and IV drug use, treating the disease and the patient. Thanks, everyone.
Answer, can I just a statement back to Sue and Andrew, if you don't mind?
Yeah, go ahead.
We should probably chat, because behind the scenes a little bit, I've been working with the Emerge guys on simulating ECMO and eCPR in the emergency department with their very well developed simulation team, and ECMO is kind of on their list of things to that is upcoming from a simulation perspective. And I didn't kind of realize naively that you guys are working on something similar for the ICU. So hopefully we could kind of, combine our efforts and until we have a formal sim team in the rest of the hospital.
Absolutely.
Hopefully that can be of some learning value for everybody involved.
Yeah. So we've had Dr. McQuan and Dr. Atkinson together. So yeah, we know what's happening.
Okay, excellent. Thank you.
Perfect, everyone. All right, have a great day. Onwards and upwards. Thank you, guys.
Thanks.